of centimeters of the trachea as well. So whatever definition you use, as long as you can say it with confidence and say that that's your, that's what your anatomical markers are, when you're in the surgical field, and that's useful and that's helpful enough. You may get asked a little bit about physiology in terms of voice production, but I don't think it'll be too detailed. Remember that the function of the larynx is not primarily speech, although speech is important. Its primary function is about airway protection and an element of regulation of respiration. But from the point of view of production of speech, what is required? There's the elements that are required to produce sound, and there's the elements that are required to produce speech. So sound requires power and the air source, and the vibratory element, which obviously is the vocal cords and the larynx. So your power source is the lungs, the vibratory element is the larynx. But for actual speech formation, you need to have articulation, and that's by the formation of the sounds that we form with our lips, our tongue, sounds around the teeth, and also the effect of resonators in the skull. But what's happening at the level of the vocal cord is something called mucosal wave propagation. And for mucosal wave propagation to happen, you do need to have a degree of subglottic pressure wave. So you do need good glottic closure to produce that. What might you be asked to draw in the Viva? I don't know if they still do drawings actually in the COVID Viva, but still, obviously you may be asked to draw a larynx like you do in op notes, or you may have done for your MRCS. And you may also be asked to draw the cross section of the vocal cords, demonstrating the vocalis muscle, the parts of the vocal ligament, intermediate and deep lamina propria, and the superficial lamina propria highlighting Reinke's space, basement membrane, and the squamous epithelium. It's nice to know a little bit about vocal cord function as described by Hirano. He proposed in 1974 the cover and body theory, which essentially talks about the frequency of voice and the pitch of voice is determined by the length and mass of the vocal fold, which is therefore influenced by the vocalis muscle, or the thyroarytenoid muscle, and the cricothyroid muscle. And this is his, this picture represents his idea that there's the body that contributes to the structure of the cover, and that's what influences voice. So be very aware of how to talk about voice assessment. This might come up particularly in your clinical examination stations, particularly as you're not actually getting to examine patients. They may ask you to talk about this. So things to know about are objective assessments of voice, such as the Grabber score or the Cape V score, and subjective assessments, sorry about the typo there, which includes things like the vocal handicap index, and in some laryngology clinics, they will also want to do the reflux symptom index. So I've covered these both, I've got captures of these both here. These slides will be available, I believe, on the course website, so you'll be able to have a look at these if you've not come across them before. I haven't gone into a lot of detail for laryngeal function and anatomy, but if you want to look at that more, then this is a very good slideshare that you can look up, and I think also might be on the Dundee course webpage. With regards to clinical stuff about pharyngeal pouch is something we come across a lot, and you see it a lot clinically, but to really sort of have a slick way of talking about it in the exam, I'd recommend reviewing this article from the 2017 masterclass. Really goes through things nicely in terms of the management and current practice. So just a reminder that a pharyngeal pouch is essentially an outpouching or a sort of false diverticulum, if you like, through the space between the two parts of the inferior constrictors. And this part is weak because it's a part that hasn't got a muscle overlying layer, so there's a weakness there. And sufficient pressure will cause then the Zenker's diverticulum to force its way through that space called Killian's dehiscence. This picture just shows that the mucosa can prolapse out. It has a tendency to prolapse out to the left, but obviously not always. There is a mention here of Killian-Jameson's diverticulum. This comes through a dehiscence at the upper edge of the esophagus. Unlikely really to come up in your Viva, but something to be mindful of. The next thing to talk about is neck trauma. I think this is one that people should really practice talking about, because you really want to talk about the principles of being safe with a neck trauma and with confidence at your actual exam Viva. So One thing I would say about any neck trauma, whether it's a blunt neck trauma or a penetrating neck trauma station, is if it's in the 5-minute station, Viber station, don't spend too long. You want to get through within the first minute or less the ATLS stuff. So that's not the focus of this station. Don't spend too long on the ATLS. You want to say that you'll be safe from an ATLS point of view, but then you need to move on to the stuff that's actually relevant to your head and neck part of the station. So what you'll be looking for is really evidence of any laryngeal and tracheal breach and damage, and then any evidence of esophageal, vascular and neurological injury. And the thing that they really want to talk about is how you're going to manage it. So they will want to talk about things such as the neck zones. So the trauma neck zones are divided into zone 1, 2, and 3. Zone 1 is the lower area of the neck. So it's the horizontal area between the clavicle and the suprasternal notch and the cricoid cartilage. And within this area, you have the thoracic outlet structures. So it includes the more proximal common carotid. You've got the vertebral and the subclavian arteries, so you know, big vascular load in that space. But you've also got important structures like the trachea and the esophagus. You've got the thoracic duct and the thymus. Zone 2 is the middle zone between the cricoid cartilage and the angle of the mandible. This contains both the internal and external carotid arteries after the bifurcation. It's also got obviously the jugular veins. We're talking about the internal jugular, but also you know, your in theory your external and anterior jugular veins could be injured and cause some bleeding. Then you've got important structures of the pharynx, the esophagus, the larynx, the recurrent laryngeal nerve, and of course the vagus nerve actually also. And then you've got the trachea, and behind the trachea, the spinal cord. The thyroid can also be injured, and obviously that's a very vascular structure, so concerns about hemodynamic impact of that. And then the parathyroid can be compromised, although that's probably not an acute problem. And the final zone is zone 3, which is the area that lies between the angle of the mandible and the base of the skull. This has the distal extracranial carotid arteries, also the vertebral arteries that we've mentioned. Remember in zone 1, we mentioned those as well. And then the uppermost segments of the jugular vein. So the thing I want to really highlight, really talk about mentoring to neck trauma for the exam, is that you should be aware of a slight change in practice. And some of the textbooks still talk about the compulsory exploration of breach of if there's breach of the platysma, or compulsory exploration of zone 2. Actually, the mindset has shifted from that. So you need to be able to demonstrate that you are aware of this, and that's how you're going to approach being a safe day 1 consultant if you have to deal with a neck trauma. So I thought this is a really helpful quote to remember. It's from the Western Trauma Association. I've put the link there if anybody wants to go look at it. There's a really nice flow chart, which I think this one's a bit busy, but this is the most up-to-date flow chart. I find this one before it a little bit more easy because it just highlights the principles. The first thing for any neck trauma, apart, once you've done the ATLS part in an A&E resus situation, is actually to assess if the patient hemodynamically stable or is it uncontrolled hemorrhage. Because if either of those 2 features are present, then yes, you're going to go straight to operative exploration. However, in the patient that's either hemodynamically stable or asymptomatic, then you start to go down the route of looking at judicious use and sensible use of imaging and sort of more planned surgical exploration if needed. And again, there's a little bit of difference between what you will do for zone 1, 2, and 3 in those 2 situations. But I guess for the exam, when you're stressed, if you don't remember the full flow chart, as long as you can remember the basic principles of how you're going to approach safely addressing and managing the patient to keep them stable and intervene in the best possible outcome for the patient, that's the important thing. Okay, so I'd like to now talk about some cases and examples. So we're going to go through some things that might come from the exam. Some of these have already come up, I think, in the clinical examination stations that you've been practicing, but we'll keep going through them. So I don't think I can ask for people to talk, which is a shame. That's what we would have done in a real face-to-face session. But so this picture, obviously, of a lesion in the larynx, and this is meant to represent to you a vocal cord granuloma. Key things that you'll cover in your history are the usual things about age and sex and comorbidities. But for vocal cord granuloma, the features you really don't want to miss in the history are: is there any history of intubation or any other reason for trauma to the larynx? and also any risk factors for reflux, because there is some suggestion that reflux has a significant etiology in the formation and kind of sustaining of granuloma formation in the larynx. And you obviously want details of how the patient has symptoms regarding some voice change and things like that. If you're going to have this clinical picture in your exam, you're going to have to describe it. So one way of phrasing, or my way of phrasing this would be, this is an operative clinical photograph showing a unilateral laryngeal lesion. My main differential for this appearance is a granuloma. However, you might want to talk about the fact that you're concerned, you would always be concerned about neoplastic change, particularly if there are any of the risk factors that have been identified in the history. Most vocal cord granulomas, though, obviously they are a benign lesion, and they tend to occur around the posterior third of the vocal cord, although that doesn't seem to be the appearance of the top picture. And the causes, as we mentioned, are usually trauma related, but you want to think about other things that could be traumatic to the vocal cords and the larynx, such as severe reflux and real voice abuse and misuse. Granulomatous conditions can also give rise to a vocal cord granuloma, like syphilis and TB, and that's included in your differential, something like sarcoid. But of course, the other thing to consider any lesion in the vocal, in the larynx, is about you want to rule out any neoplastic change, particularly if it's a malignant neoplastic change. So examination and investigation, flexible nasal endoscopy, obviously, hence you've got the photo, but ultimately you're likely to go for a microlaryngoscopy and a biopsy of this, both from a diagnostic and a treatment point of view. So they'll talk to you about management, and your principles of management of a vocal cord granuloma is 1, to exclude neoplasia, and 2, to try and optimize the voice. So removal of the lesion will help the voice, but how do you keep maintaining or optimizing it? You will involve things like vocal hygiene and input from our speech therapist to optimize that. If the patient does have evidence of reflux or has a history of reflux, then you can optimize their anti-reflux regime. And there is some, I've not come across this, so if any of the consultants want to add, but use of Botox to reduce strain, and surgeries to reduce the traumatic effect or traumatic strain through the vocal cords. If you have more time, the kind of things they might ask you, or if you're doing really well in the exam and you've still got time at the end, they might ask you about how would you manage a recurrence of a granuloma? Would you take them back to theatre? Are there any other topical treatments that you could use to reduce their recurrence? They may ask you about pathophysiology and the etiology of how a granuloma forms. I think what's more likely, and this is for most of the laryngeal things, is that they will talk to you about how you perform microlaryngoscopy. And that will include things like what's your technique for positioning the patient? Do you have a preference of what laryngoscope you use? Which laryngoscopes you use for different types of access and views that you need. And I suppose for a large lesion like this, they could take it down the route of talking about airway compromise and airway issues, and how would you manage that. This is just a picture of somebody doing a cold steel excision of granuloma. So the next pictures are of benign pathology in the form of polyps or nodules. So remember that polyps tend to involve the free edge of the vocal cord. So if you're going to describe these pictures, for the top one, I'd say that this is a clinical operative photograph showing a unilateral lesion off the free edge of the anterior 1/3, 2/3 junction of the left vocal cord. For the lower picture, if you can just about see, I hope it's coming up, but there are sort of a mid-membranous or anterior third membranous symmetrical bilateral lesions of the vocal cords. So the lower picture is more consistent with vocal cord nodules. Important feature that you must include in the history for this is about any evidence of vocal cord trauma or voice abuse. Not so much about intubation type trauma, more about voice use trauma. And again, reflux is a contributor, and you want to know about their existing vocal care and hygiene, if they have any at all, or if there's anything in their voice usage that predisposes them to this. Particularly, remember this can also be a case in pediatrics. Pediatric station might be child with hoarseness, and their tendency is to be vocal cord nodules. So again, this is the kind of thing, there's some overlap here of what you would be covering in that scenario. Investigations, as with any of the other laryngeal pathologies, is a nasal endoscopy and neck exam. And particularly, I would say for vocal cord nodules, you want to do stroboscopy, because it's really, it gives you an idea of the kind of degree of vocal cord trauma in terms of how voice is being formed by this particular patient. But then ultimately, again, it's going to go to direct or microlaryngoscopy. Differentials for these appearance, do be mindful that when you have a vocal cord polyp or even probably a vocal cord cyst, you can get a contralateral reactive lesion, and that might throw you into thinking that you've got somebody with bilateral vocal cord nodules, but actually it's a unilateral lesion with a contralateral reactory change. But occasionally these unilateral masses are actually some sort of fibrous mass, or you could find out it's a cyst or a pseudocyst. And it's obvious when you try and excise the lesion that it just sort of bursts, and it's a cyst that you've unroofed. So management for both these benign pathologies is addressing risk factors involving speech and language therapy. And then, you don't necessarily go to surgery straight away. So you will want to re-examine or do some degree of regular monitoring or review if there's no improvement, or if the voice symptoms or whatever the symptoms the patient is presenting with have become worse. Having said that, for a unilateral lesion or a unilateral polyp, you may wish to say in your exam, and you would not, I don't think you'd be penalised if you argued that actually you would go for a general anaesthetic examination and a biopsy fairly early, particularly if you felt in the history there were any concerning features or risk factors. The patient was a heavy smoker, or this onset of symptoms was very rapid, or anything like that. And or for example, they didn't have the other benign risk factors, they had more of the serious risk factors, and you'd probably take them to theatre earlier. As with the other conditions we mentioned earlier, I think your higher level questions will be about more about how would you do this? How would you perform microlaryngoscopy? They might talk to you about operative techniques, because this might be an opportunity to ask you to talk about laser. And they may ask you about what does speech and language therapy do for these sort of conditions, or what vocal hygiene would be helpful in these conditions. But again, I think these are things that if you had got through all the basics, they might go on to at the end. But it's useful to have an off-pat answer for this. And the other thing I would say is that if you've not yet had a chance to see actual stroboscopy, do try and get in with a speech and language therapist, just so that if you have to describe it during the Viva, it doesn't feel like you're describing something you've never seen. And then the next patient we could look at is the vocal cord palsy. Very important to ask about risk factors in this and associated symptoms. Particularly, we're talking about things to do with aspiration, and not just to do with voice change. And then about risk factors related to any reason they might have another malignancy, a non-head and neck malignancy, particularly we're talking lungs and bronchial. So how would you describe this? I mean, this is a single photo, so it's not great, but for example, in the exam, you may have something where you can see that the cord is short and fat. So this clinical photograph suggests, as an example, a foreshortened, lateralized, flaccid left cord. And in this particular photo, you can see that there's laxity or subluxation of the aryepiglottic fold and the arytenoid cartilage anteriorly, kind of into orthoglottis. Ideally, you would want a dynamic assessment of this patient with flexor endoscopy to assess the vocal cords, but you're concerned about unilateral vocal cord palsy. The differential for this kind of appearance, or maybe not so much for the short fat cords, but when you've got this kind of flopping appearance of the larynx, is if there's fixation of the cricoarytenoid joint that can happen in, for example, rheumatoid arthritis. Your diagnoses, your differential diagnoses, includes malignant disease probably at the top, and that's the most important thing for you to rule out. But this can of course be iatrogenic if somebody's had cardiothoracic or even neck surgery, and it can be idiopathic. So your investigations, as with all the other laryngeal pathologies, will include a flexor endoscopy and a neck exam. But for vocal cord palsy, don't forget to do a full cranial nerve exam, or to say that you would do a full cranial nerve exam. Stroboscopy and electromyography may be helpful here. Electromyography, perhaps particularly if you thought the patient wasn't great for a GA examination. Sometimes electromyography is useful because it can distinguish between there being a paresis, a cord paresis, and therefore a suggestion that if there is no cord paresis, that maybe we're thinking about fixation of the cricoarytenoid joint. Management of a vocal cord palsy really depends on the pathology and the degree of impact or symptom disability that it's causing the patient. If you've got no underlying other pathology that needs management, then you can focus your management really on symptomatic management. This might be simple speech and language therapy input, and measures to make sure they're reducing their aspiration and trying to optimize their voice as best they can with vocal therapy. But it could also include things like injection augmentation or remedialization for laryngoplasty. I think there's plenty to talk about in vocal cord palsy. I think it's unlikely that you'll be pushed for higher order questions, but if you did have time and get to that point, they may ask you to describe electromyography. They may ask you to describe how it's done, or they may ask you to describe what its principles are. You probably just need a short answer for that, but I wouldn't spend too long learning about electromyography. Vocal cord injections, I think, is a useful one to talk about. A bit like they might ask you about microlaryngoscopy. They might ask you about how you have done vocal cord injections, or if you've seen them being done, and also the materials that you're aware of, so Menieres and those kind of things, and what you know about their time to degradation and repeat procedures and that kind of thing. I'm not sure how much they would ask about thyroplasty surgery, mainly because I'm not sure that all trainees get to see it prior to the senior years of training. But if they do get to that point, remember that as core principles, thyroplasty surgery is surgical improvement of the voice by altering the thyroid cartilage, and the surgery is on the thyroid cartilage itself. Type 1 thyroplasty surgery is generally a medialization thyroplasty surgery, which is the one that you would be thinking about in the context of a vocal cord palsy. Type 2 thyroplasty isn't really relevant here because it's a lateralization thyroplasty and tends to be done for sort of spasmodic dysphonias and things like that. Okay, so the next thing to think about is pharyngeal pouch, which this radiograph is of this capture from various was obviously showing. And really important is, I think, in the head and neck station, the pharyngeal pouch, a lot of your points are going to come from the history. So make sure you really cover the key history points. Don't get too distracted, if you like, by the cancer discussion. If those points aren't coming through in the history early, and it's very clear to take you down the pharyngeal pouch route, then focus on trying to get through those history points. And so remember the key points that apart from dysphagia, you need to identify if the patient's having immediate or delayed regurgitation, particularly of undigested food, and evidence of weight loss is concerning. Alongside that is concerns around evidence of aspiration. Either this can manifest as a patient saying that they have sort of embarrassing choking episodes, or if they're eating out in restaurants and that's what's bothering them, or actually more worryingly, that they've had recurrent chest infections and no one's identified why they're having these recurrent chest infections. When you're describing the film, this is a single frame capture from a contrast follow either of barium or gastrography showing a pharyngeal pouch. Just one sort of overall exam tip I'm going to give is that for any of the stations where you've got like an image or a picture to start the station, don't spend too long describing the picture. Get quickly to the point of what they're trying to show you. It's a bit of I know it sounds a bit sort of basic to tell you this, and I'm sorry to do that, but really switch your mindset from what you were doing for previous exam preparation or ST3 preparation, because your points aren't going to come in that first minute, or your points aren't going to come from the first stage of just taking the history or just describing the findings. They're going to come from the later part, all to do with the management. So when you're practicing now with your colleagues and your friends, the initial part, you want to get all that basic information out perhaps in the first minute to a minute and a half maximum. So the remaining 3.5, 4 minutes are actually focused on getting through the points that the examiners need to tick off on the exam. So this is a nice case to remind you of that, because I think pharyngeal pouch, we see it so commonly that we can spend quite a lot of time just talking about the basics, where actually you want to move on to the next part and get to the point of actually talking about the surgery. So obviously the diagnosis here is a pharyngeal pouch, but you will mention that you're mindful of malignancy, both from the point of view of a malignancy being the reason the patient developed the pressure gradients of causing the pouch, but also the pouch itself can have a malignancy within it. So as with all of these, your examination is going to include flexible nasoendoscopy. You will examine the neck, although I still haven't, and I don't know if I've worked with a consultant who said they felt a pouch on the outside of the neck, but you've got to palpate the neck. And you would move on to a contrast study if it's not already done, but obviously in this case you're being given a photo, so it has been done. I would say that you would auscultate the chest, particularly if you think, if in the history they told you that there's been episodes of aspiration or there's been chest infections. I would, particularly in the clinical stations, I would include that. I would auscultate the chest. And they're likely, particularly particularly in the clinical stations, if not in the Viva, 5-minute Viva, to ask if you know any gradings of pharyngeal pouch. I think it's entirely reasonable to mention that you are aware that these classifications are somewhat limited in their clinical utility, but they are useful to have as an approach to understanding and thinking about how you're going to intervene. It's nice if you can remember the eponymous names for them. Not everyone does, but Morton and Van Overbeek are probably the ones that people mention most and talk about most. But I think they just want to, for any classification, I think they want to know that you know them. They don't necessarily, but you know of them. They don't necessarily want you to regurgitate the whole classification, but if you can, that's fine. So obviously the management of pharyngeal pouch, you know, like I said, it's one of these things that we see so often that we can make it very straightforward, and and that means that actually in the exam you might miss key points. So do remember that there's both surgical and non-surgical management of pharyngeal pouch, and there's quite a lot that can be involved in the non-surgical management. You will definitely want to include speech and language therapy because they will give advice about maneuvers that might allow someone to avoid needing surgery, and particularly in the patients that aren't great surgical candidates, or perhaps this is a recurrence, you know, they've had 2 or 3 interventions previously. Be mindful that if somebody is really having nutritional compromise because of a pharyngeal pouch, do you need to be thinking about alternative enteral feeding if they're not a candidate for surgery? Botox injection is something that I've seen used for spasmodic cricopharyngitis without a formal pouch, but I don't know if maybe some of the consultants in the faculty do use it for actual pouches, and that's something to discuss further. But ultimately, surgical management is either open or endoscopic. In open pharyngeal pouch surgery, you achieve a cricopharyngeal myotomy, and then you do either a diverticulectomy or a diverticulopexy to stop the pouch being something that food can go into. Or there's endoscopic, which perhaps most of us are familiar with, where you use a diverticuloscope and then an endoscopic linear stapler, and you use that linear stapler to do a diverticulostomy between the posterior pouch and the anterior esophagus across that bar of tissue that you're seeing, which is the cricopharyngeus. And this creates a common channel, and that's what reduces the chance of food pooling and regurgitation. If you have more time, I think what they might ask you to do is talk you through how to do an open repair, and maybe the pros and cons of open and endoscopic repair. I think in my Viva, I did get asked to talk through an open repair, even though I hadn't done very many. But so practice talking about that, and you should be fine. So I'm just going to end on some general exam points that the consultants who wrote this slide really highlighted, and I think they're quite helpful. I sort of touched upon this earlier in the talk. You need to get to the point of what they're trying to assess you for in the exam as quickly as possible. So I don't mean have pressure of speech and rush through, but what I do mean is don't dilly-dally in getting to the point that then allows them to start asking the questions that they need to ask. Having said that, do listen carefully to the question that's being asked and answer that question. Do as you're asked to do, particularly in the clinical examination stations. For you guys, it's going to be strange because you're doing it over this platform, and you might be just describing things rather than actually examining a patient. So just be very mindful of what they're asking you and try to answer that very deliberately. You probably will be still having photos, and they are generally better quality. I had photos at mine, even though I had a face-to-face exam, and they were fine. Don't get hung up on if the questions are difficult, because those are the questions that are testing your higher order thinking. And if you've got to that point, it means you've probably got through all the easier questions fine, and that's why they've got to that. I'm sure this came up in your talk about the cancer stations, but you can't get away with just hiding behind the MDT. And my tip for that is, if you are going to mention the MDT, be specific about what you're expecting the MDT to contribute or do for the benign cases, rather than just saying I have a multidisciplinary approach and I involve salt. Specify what you're expecting them to do. And we mentioned about not being too slow. At the same time, don't race through so fast that you're sort of jumbling your answers up. But yeah, I think the most important thing I can say is practice, practice, practice. The more you're verbalizing things with people, the less likely it's going to be difficult for you on the day. But from what I've seen in the session so far, you guys are doing really well. So best of luck.
Brilliant. Thank you very much, Ruji. That's a great talk. It's again a lot of points, small tips, but all of them, like for example, neck trauma, pharyngeal pouch, these are all definite stations, and also benign laryngeal lesions. Thank you very much, Rajita. Good. Um, I don't think any questions in the chat, but that's good. So I'm going to move on to Patrick Spielman's lecture, which is going to be 30 minutes again. He's on call, so he managed to record, and so I'm just going to share this talk. This talk, possibly you may have to increase your brightness. I feel
highly on some of these vivisations. I'd expect you to know all the basic stuff, so we might gloss over some of that and try and get for the evidence and the sort of the finishing touches, I guess. So I guess you should understand or know that it's a complex condition with 4 major symptoms: fluctuating hearing, fluctuating tinnitus, oral pressure, and vertigo episodes. When you start talking about this in a Viva, you probably can touch on the etiology. We don't really know what causes it, so it's fair enough to say that the etiology is poorly understood. That you can touch on genetic causes, allergic causes, autoimmune causes, but there's not that much to talk about there because we don't really know what causes it. The final common pathway of endolymphatic eye drops is probably what you should really be talking about, what we do know that there's good evidence for. If you talk about the incidence, that's difficult to define because the incidence varies depending on which population you study and what your definition for Menieres is, what you're using as your definition. So the incidence I've seen vary tenfold. I use a sort of in the middle picture something about 20 and 100,000 as your sort of average of lots of studies depending on what you've looked at. You should know your criteria, so your definite and your probable criteria. You should know that it was updated in 2015. I first did this talk in 2016, so that's why I was playing on it. But the 2015 criteria you need to know. You need to know definite and probable. And if your definite is 2 or more episodes of vertigo lasting for 20 minutes or more, with hearing loss that you've documented on an audiogram, at least once. They will have fluctuating symptoms, whether it's tinnitus and fullness in the ear, and you've not better accounted it for by another diagnosis, so an MRI scan, in all intents and purposes. By the way, if there's anything that doesn't make sense, just shout out. This is quite informal. I've got no problems if you've got a question. Just shout out, stick hand up or something. That's fine. Yep.
So you have to have more than one hearing test.
No. No. It's nice, but that builds on the probable criteria here, where you've got all the symptoms, but you've not got the hearing loss. You've not captured that drop. Now, if you've documented, so we're doing a multi-center RCT, and they just want to show the hearing loss, whether it's low frequency or just difference from the ears. So in this sort of revision, certain and possible have been removed. So it's only definite and probable. Okay. That's your typical audiogram that you might get as a starter for 10. Talk me through this audiogram, what you see. This is your typical low frequency sensory hearing loss. Okay. Your investigation really is your MRI scan. I would do nothing more, and it's fair enough to say I would investigate no further. Lots of people want to talk about VNGs and calorics and so on. It's not going to provide you much more information because the diagnosis is clinical. The only time you're going to use a caloric or some other investigation is if you're going to do something to the ear, particularly if you're going to do something ablative, for example, intratympanic gentamicin. I don't think you need calorics or anything else at all. Of course, if you want to talk about it, that's fine, but you're not going to be penalised, and that you can rationalise it by saying that. Okay. Where you certainly start picking up the points is going to be on ladders of treatment and evidence for the investigations or the interventions you're going to offer. So I'll talk about the evidence in a minute. About this is your ladder of treatment. The wrong way around. So you start at the top and work downwards, or work the bottom and the top. So you start with dietary modifications: salt, caffeine, alcohol. The evidence for those is poor, but that's what pretty much all of us will try and talk about. Okay. Oral medication, beta-histine diuretics. Many people will already be on that. I'll talk about the evidence for that in a minute. Next layer would be intratympanic therapies, steroids or gentamicin, and this really has become my first-line treatment now. Intratympanic steroids is pretty much my first-line treatment. Beyond that, a little bit more intervention: a grommet plus or minus a Menieres device. Any of you come across or heard or used or seen some use a Menieres device? Positive pressure is the other thing that people call that. It can work. We've got 2 people in TASER with it. The evidence is pretty average again about it, but I'll show you that in a slide in a minute. Next layer, a little bit more intervention again, intratympanic gentamicin or endolymphatic sac decompression. And then at the top, if you like, labyrinthectomy or vestibular nerve section. So that's your basic ladder or sort of scalability treatment. What you've always got to think about, and it's worth talking about sometimes, is bilateral Menieres disease. So if they've got one, if you're going to do something ablative to one ear, you've always got to think about what's going to happen in 5 years' time, 10 years' time, if they develop it in the other ear. So that's why we're pretty much now ultra-conservative and trying to avoid anything ablative, because we've all seen problems with somebody getting it in the second side. I've certainly inherited lots of people with labyrinthectomies done in Dundee over the last 20 years, and now I'm a bit stuck because you can't do much for you. You're a bit limited. So this is your kind of evidence summary. And it's really nice. Menieres disease has lots of Cochrane reviews. So if somebody tells you, why are you doing that? Or why are you not doing this? It's great to say, look, there's a Cochrane review on this. And the reason I'm doing this or the reason I'm not doing this is because the Cochrane review says it's great or it's not great. So for beta-histine, there's insufficient evidence that it works. There are lots of trials. Mostly are inadequate, but some suggest a reduction in vertigo. There's a particular trial that I'll talk about on the next slide, which is really useful for you. Diuretics, again, the Cochrane review says there's insufficient evidence. Intratympanic steroids, the Cochrane review supports that. So there's good evidence or decent evidence for that. If it's good enough for Cochrane, it's good enough for us, okay? So there's good evidence that that works. Intratympanic gentamicin, again, 2 trials demonstrate that it works. So this is where your evidence is starting to rack up with that sort of level of treatment. Endolymphatic sac surgery, insufficient evidence, a couple of trials on it, but as with most Cochrane review, surgical studies don't do very well today because it's difficult to properly randomize and blind. Positive pressure, 5 trials in the Cochrane review, but insufficient evidence to say it works. So this is really quite a nice chat to have for your examiners. It's worthwhile mentioning this RCT in beta-histine was published early 2016, I think maybe 17. Michael Strupp was a neurologist in Munich who was dead keen on high-dose beta-histine. He published lots of papers saying this really high-dose to beta-histine is brilliant, it's safe, it works really well. Then they designed a perfect RCT, so high-dose, low-dose, and placebo, and the outcomes were exactly the same at 9 months. So we can infer it is actually a placebo. Now, it had a 40% response rate. Great. So that's quite a big placebo rate. But if you're aware and you're comfortable with you giving a placebo, that's fine. Beta-histine costs about £2 a month. It doesn't really have many side effects. So as a placebo, it's quite useful, quite a good thing to use. You just got to be aware of it. So another good study to quote is the London RCT where they compared gentamicin and methylprednisolone given at 2 weeks. Both had a close to 90% response rate and no difference secondary analysis at 24 months. So that tells you there's not massive benefit in using gentamicin over steroids, and the side effects are obviously much less for steroids. So that's become our frontline, sort of first-line treatment because of this study. Is that okay for everyone? Yeah. Indications for surgery. If you're getting onto this, you're doing great in your Menieres Viva. I would say it's pretty unusual because the success rate of steroids or gentamicin being 90%, you're going to have only a few people who are ever going to get to this level. And your 2 options in that circumstance would be a labyrinthectomy. That will get rid of the dizzy attacks, but it's going to cause imbalance and they're going to lose the hearing. Or a vestibular nerve section, you're going to get rid of the vertigo, they're going to lose their balance, but you're hopefully going to preserve their hearing. Again, in that circumstance, it's very worthwhile mentioning the difficulty in managing the second side if it ever comes to it. So you want to be very selective about offering that. You certainly wouldn't want to be going straight in. Any questions about Menieres disease? Oh. Okay, otosclerosis. Worthwhile talking about the genetic etiology. There's London and Oxford, I think, are maybe studying this at the moment. So we know there's an autosomal dominant inheritance pattern with variable penetrance. There's a couple of genes that have been recently isolated in the UK. So again, it's worth having that in your back pocket if it comes to it. We know that measles is involved somehow. We found mRNA in the stapes and antibiotics in the perilymph. But we've all either been vaccinated or have had measles. So we don't really know what role it plays, but it's definitely involved in some way. It might be worth commenting on that it worsens during pregnancy, and women should be aware of that. So typical diagnosis is going to be conductive hearing loss with this audiogram. You should really be able to describe and explain what a Carhart notch is quite comfortably. You will probably normally see a normal tympanic membrane. We've got this odd, occasionally you get a Schwarzer sign, but that's going to be pretty unusual. Normally you're going to have a normal tympanic membrane. You should be able to explain acoustic reflexes. If you can't, we can talk about that tomorrow or next day, or there's audiologists here who again are going to be able to talk you through very clearly acoustic reflexes, so you've got that in your head. Vertigo, you can ask about that. It does happen quite commonly. We don't know why. Maybe related to Scarpa's ganglion degeneration, but it's quite a common finding in otosclerosis. You should know that tympanometry is normal. Speech audiometry, we like doing that. Many centres like doing it if you're going to operate on somebody, so speech audio is quite a useful thing. So again, having seen some speech audio, have you all seen some speech audios? You're happy looking at them and talking about through what it is. So again, if you've not, then there'll be some audiologists here tomorrow that you can look through these things with. So just be comfortable if somebody's going to give you one of these investigations, or you're going to ask for these investigations. I'd like to get reflexes. Be prepared to talk about what you're seeing. Okay. On this CT scan, I suppose that's a little bit controversial. I wouldn't say it's standard investigation. Some people would say it's a standard investigation for conductive hearing loss. I don't think you're going to be penalised by not saying it, but if you do want it, you might get given one, and therefore you should be able to find the abnormality. Okay, so the abnormality, if you can see that there, is this little lucency here, this little dot at the front of the stapes foot plate here, and again here. So that's a lucency at the fistula antifenestrum. What's another good reason to scan in this condition? Cochlear involvement, okay, yeah.
Facial nerve status for operation?
Facial nerve position, that can be quite tricky and just in these sort of scans, but some people do it for that. Perilymph pressure, somebody said, that's good, yeah. So you can get that in X-linked disorders, can't you? So X-linked deafness. Sometimes you can get clues that there's going to be a gusher. The other one I've been caught out on is a supracanal dehiscence. So when somebody's had an apparent conductive hearing loss, and they mentioned maybe not given all the classic symptoms, but they've had a supracanal dehiscence. So that's the other one that can cause an apparent conductive hearing loss with normal tympanometry traces. So your management should be watch hearing aids and wait for a few months to see how they get on with that. That pretty much should be your standard conservative, not going to rush in on surgery on this sort of patient. Fluoride certainly could be used if somebody's got a progressive sensorineural hearing loss. That might be something you want to consider and know about. The evidence isn't great, but that's be something that they might talk about if you're getting to the end of your otosclerotic fibre. Bone conduction device, so a BAHA, certainly would be an option, and in some centres that would be what you're getting for otosclerosis. So a risk-averse surgeon would give you a BAHA. Many times you'll come on to stapediectomy and stapedectomy and have to talk about the consent process, how you're going to do the procedure, or what you're going to consent to before. Stapedectomy is not a day one surgical operation, but to be able to talk about the pros and cons and the risks certainly is. They might ask you what the rate of decline is. That's the rate of decline. I usually say about 1 decibel in bone conduction and 1 decibel in the air-bone gap. So 2 decibels per year deterioration, or 1 decibel in the air-bone gap. So that's 10 decibels in 10 years. So often you wait, don't you, until somebody's flipped their release negative. So you might want to wait until there's about a 20 decibel air-bone gap before you operate. So you can sort of prognosticate that that might take 5 years or whatever, if you've got a 10 or 15 decibel air-bone gap. Okay, so fluoride 50 milligrams, I think, is the dose. I think, but there's no level 1 evidence for using it. But that's the one thing you could probably consider. Okay. Come on to surgery. So the complications, you need to be able to talk about chordae tympani injury, and the fact that it's usually short term, but there's probably a couple of % have long term chordae tympani symptoms if you divide the chordae tympani. You need to be able to talk about dead ear risk, vertigo, reparative granuloma. Some people will get, I know there's some vivisations where people say they come back 10 days later with dizziness and notice worsening hearing. And you need to be able to talk about these sort of complications in that circumstance and what you're going to do about it. We should know that your target outcome is going to be airborne gap closures less than 10 decibels, and you want to be achieving that in 90% or greater. That's going to be your target. It's obviously not always going to be achieved, but that's what you're going to be wanting to consent somebody for. That should be the figures. Okay, lastly, if we just touch on auditory implants. Again, we'll have a few for you to look at tomorrow. Most of you seen these sort of things? Yeah, most of you in centres where you're going to Birmingham, I believe, are you? Yeah, so you're going to get them because they have a big BAHA program there. They have middle ear implants. They have quite a lot of funky new implants as well. They certainly have cochlear implants. So you should be able to be fairly confident with these, both in your Viva, but particularly in clinical. So we need to talk about indications. We need to talk about the types of bone conduction devices that are available. We need to talk about semi-implantable devices. When I say semi-implantable, they've got an external processor, but they're sort of under the skin. You might come across single-sided hearing loss patients, either in the clinical or in the Viva, and probably complications. I'll just touch on that. So I divide my indications into patient factors and audiological factors. So there are patient criteria that they need to meet and audiological criteria they need to meet. For a patient, it's pretty much they can't wear a hearing aid. Whether it's because they've not got an ear, they've got an open middle ear, they've got a tight externa, or whatever. They can't wear a bone conduction, a standard BTE aid. Your audiological indications will vary depending on the implant that you're going to offer. So these are broadly, if you've got a conductive and mixed hearing loss, you're going to get any of the above. But your bone conduction threshold has to be 45 dBs or better. There is a bit of a slope to it, but if you use 45 dB as your benchmark, then you should be okay. These graphs on the right are the Med-L criteria for BAHA and bone bridge at the top, and the vibrant sound bridge at the bottom. So for sensorineural and mixed hearing loss, you can offer a vibrant sound bridge, and that's this criteria here. Now this is the air conduction, not the bone conduction. This one, you're looking at the air conduction. On this one, it's the bone conduction. Okay. And for single-sided deafness, you can't offer a VSB because that aid doesn't work, but you can offer a bone conduction device, so a BAHA or a bone bridge. And on that, you really want the bone conduction thresholds and the contralateral ear to be 30 or better. You can get away with a little bit more nowadays with superpower BAHA, but 30 or better is really ideal.
The sound bridge is one that on the optical.
Yeah. That's right. Yeah. Yeah. So bone conduction broadly is the oldest system available. They are relying on direct stimulation of the cochlea, so via bone conduction straight through here into the cochlea. Two manufacturers, Cochlear and Oticon. Lots and lots of people have them. You can't guarantee anything in life, but you're very likely to see them down there in Birmingham because they started the program really early. They have a lot of people with them. You could probably talk about the advances in the surgical technique that have been happening. Back in the day, it was thin the skin out, make a wide bed, if you like. We've moved away from that. There's now minimal soft tissue reduction and just drilling the bone straight in, early loading of the implant after 3 or 4 weeks, and often it's a local anesthetic procedure. You should probably, have you heard of Holger's skin reactions? Yeah, some nods, yeah, it's good. That's what we use as an outcome measure. So up to 2 was considered a good outcome. That would be acceptable. 90+% of patients will probably have, well, 85 to 90 would have one of these scores. Not a good outcome would be 3 or 4. I think overall the figure of implant loss in bar heart is about 8%. That's obviously higher in kids, even higher in kids with syndromes, but overall your figure will probably be about 8%. So that's implant gets so infected or actually falls out. That's big series. That can be, so you can sort of work around that by using a bar heart attract. But bar heart attract has problems as well because you're using a magnet to squeeze the skin, and therefore you can get some skin necrosis, and you get some attenuation through the skin. These are some pictures of complications of the bar heart attract from Toronto, I think. But again, that's just a variation of a bone conduction device. I think you're going to probably see these in pediatric cases. You need to be able to talk about the conditions that can be involved here, Treacher-Collins, Down syndrome. And if you get a case like that, you want to be talking about the quality of the bone. So it's going to be poor. There's going to be much more likelihood of skin overgrowth. Complications in children up to 20%. So 1 in 5. That's why parents need to be counseled a lot on cleaning and the risk of trauma. Children go and bump their heads and it falls out. So they've got to be really a bit careful about this. And that's why many surgeons will offer 2-stage surgery. So put the screw in or put 2 screws in, cover them up, and then come back 3 months later and allow a second, then put the abutment through so the bone, so that the screw has osseointegrated. So it's really taken. Whereas in an adult, you're going to get a single shot procedure, you're going to get your implant after 3 or 4 weeks. So it's just that subtlety of differences, okay? Vibrant sound bridge. So this is the one that you mentioned there. This is where you get direct drive of the ossicular chain. You have a variety of ways of attaching this onto the middle ear. So this is the 2nd generation device. These are little flanges to hold the processor in place. This is the coil, and this is the little business end. This is the FMT, floating mass transducer. And this little thing can be attached onto a variety of bits of the ossicular chain. This is the short process coupler. This is probably the easiest and sort of first choice approach if you can get it. It can be attached onto the long process down here. If you've not got an incus, it can be attached onto the stapes. And if you've not got a stapes, it can be attached onto the round window. And that's probably your order of preference of insertion, A, because of ease. There's a little bit of data to suggest that a long process coupler, so having it vertically here, provides greater gain than it does here. That would probably make sense, but you're only talking a couple of decibels. So it's probably not worthwhile going for the greater procedure, posterior tympanotomy and so on, if you've got quite an easy procedure here, unless they're right on the limit of the criterion, okay? This would be a fairly typical clinical case. I realise the audiogram here is the other way around, but he does have bilateral hearing aids. So if you zoom in, he's got a bit of an otitis externa here. He had trouble wearing hearing aids, and this is a 1st generation processor. So this is what it looks like. You might get a kid with a scar and a processor on the back, and then you'd probably want to look in the ear and talk about the sort of conditions he may have had. The audiogram here just shows a unilateral conductive loss. Obviously, it's the wrong ear for this picture, and I apologise for that. But this sort of hearing loss, you could pretty much get away with any of the implants, couldn't you? Yeah. Bone conduction better than 20, 25. Air conduction here around about 45. A little bit of high frequency loss here. So the sound process, the vibrant sound is probably better for this high frequencies, but that's really just the small. You can pretty much get away with any implant for this type of hearing loss. So this is the bone bridge. This is implanted in the bone behind the skull. Very similar in fact, the same technology, just scaled up. So the technology in the floating mass transducer is the same as in that. This just vibrates up and down. These screws attach onto bone, and the whole thing vibrates in a well, and that just uses bone conduction. Same criteria as for Baha, so better than 45 decibels across the board, but better than Baha probably because it's got no wound, better cosmesis, less complications. The downside of this, it's quite bulky. So it's difficult to get into children, and some adults will feel discomfort and pain because it's quite a big device. Sorry? Loosening? No, the problems we've had have been infection, as with any implant. So we've had a couple of explants. Looking at, there is data from all this, most centres have been submitting. There's not much on loosening, no. Okay, so this is an example of a clinical case you might get. You might get a atretic ear with going bilateral conductive hearing loss. And the issues here you want to talk about are going to be patient and audiological. Audiological is good for everything. Patient, you're going to have to consider they may want to have auricular reconstruction down the line. So sticking a dirty Baha on the outside may not be the nicest thing if you're going to want to go through multiple procedures for a more cosmetically acceptable ear. So this is where the bone bridge or the sound bridge are useful. And then you've really got to look at the middle ear quality. So what's available? Is there an incus? Is there a stapes? Is there a round window? Can you get there? Where's the facial nerve go? And so on. So you're talking about, what's the criteria? What's it called? Jahresdorfer? Middle ear? Yeah. So you're looking at, if you get into that, you're doing great, by the way, but if you want a CT scan and to assess what's going on in the middle ear. More and more centres are going for a bone bridge in these circumstances. Just because it's easier. Have you seen the ad here, anybody? Some nods. So this is an adhesive device. You can see here, this is stuck on the back, onto the mastoid bone. And this works just like the others. It vibrates away. And if you've got very good bone conduction, but a good bone conductive hearing loss, this is a really good solution. We've used it in kids. We've used it in adults perioperatively, when they don't really want to wear a headband, softband, for example. Here, this sort of plastic one, you've got a bit of a tight sterner here, and you've got this on the back. So this is quite a nice, sometimes permanent. It's only been out for a couple of years, so we don't really know if it's going to be permanent, but it's definitely a good perioperative measure, or for short term, we've used it and we quite like it for that. Probably works as a trial as well, as a sort of take this away, use it for a couple of weeks and see what you think. Yeah. I'll come on to that. You mean for that one? Is it good enough? We've not used it for that. I guess theoretically you could use it if the other side was perfect. Yeah. I don't think we've used it for that, but it should do. It should do. You're going to get a bit more attenuation, but if the other side's good enough, then it should be fine. So single-sided hearing loss, useful to talk about. Why do you get it? Sudden hearing losses or vestibular schwannoma, either preoperative or postoperative, for example. Problems they're going to get are going to be hearing in background noise and sound localization. Most of people with that problem adapt and just cope with them. Maybe it's because they've been through an awful lot of surgery to get there, who knows. But only about a quarter of patients with a VS take up the offer of an implant for single-sided hearing loss. And about a third of people with a sudden sensory hearing loss as an adult take up the offer of an implant. So it's a pretty low, small group of people. That might be patient factors, that might be occupational factors, things to talk about, you know, these are the issues. One route of getting through a single-sided hearing loss viva is trying a cross-aid. Non-invasive, simple, cheap, and if they like the sound but don't like wearing two hearing aids, then we usually step them on to an implant, and then a bone conduction or a Baha would be, a bone bridge would be the options of choice there. Again, it's another quite a good one for a clinical case. I think I remember that going on when I was there. Okay, so that's me about half an hour. Any questions on?
Criteria. Perhaps I misunderstood this. I thought that you are super parent.
That's great, guys.
No, you're right. Everything.
Brilliant. I think we come to the end of the course. Sorry, we are kind of 10 minutes late. Hopefully, it shouldn't bother you much. Thank you for today. Wonderful faculty and delegates. I think you all managed very well. Please, some of you had some problems in changing over today. Please make sure you update your Zoom. That works well in most of the time when you change over the breakout rooms. So tomorrow we'll start at 8:30, and there will be loads, kind of 10 stations. There will be kind of loads of kind of moving around. Please make sure you update your Zoom, and otherwise we can still move you. It's not a problem. Thank you. I'm going to end the meeting. Thank you very much, everyone. Bye-bye. And the link is going to be the same for tomorrow as well.